Well, I am delighted. Welcome back from your energy break. I hope folks got up and stood up. If you've joined us in prior years, you'll know I'm a big proponent of getting yourself moving between these breaks. My name is Kristen Koska. I am the director of the OHDSI Center at the Roux Institute at Northeastern University. And it is my esteemed privilege to be able to be part of this reaction panel. I don't even deserve this. There's so many cool questions that we're going to ask these wonderful panelists. So to kick it off, I'm going to introduce our panelists and then have a few seed questions. And of course, we'd love to see questions come up in the chat. And I know there's been some really great discussion going on, so I will do my best to keep an eye on that. And we're really looking forward to hearing just a reaction to what you've seen all day. So I want to kick it off. And first, we know who Yasser is. He is our first author, who is the most collaborative first author I have ever met. No offense to anyone else on the line, but how rare is it to have somebody join and say, yep, you can look at my paper. So thank you for joining, Yasser. We are just so delighted to have your expertise. And alongside you, I'm going to kind of go Hollywood squares here. Dr. Shirley Wang is an assistant professor of medicine at Harvard Medical School and associate epidemiologist in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital. She's a pharmacoepidemiologist focused on developing innovative, non-traditional analytic methods to understand the safety and effectiveness of medication use in clinical care, as well as facilitating appropriate use of complex methods for analyzing large observational healthcare data. Dr. Wang has an extensive background, including experience with the Sentinel Initiative since 2011, as well as Joint Task Force with ISPE and ISPOR, and the Repeat Initiative, which she can comment on. It's a nonprofit program with projects designed to improve transparency, reproducibility, and the ability to assess the validity of healthcare database studies. We are honored to have Dr. Shirley Wang. Thank you for joining us. I want to introduce next to her, we have Dr. Thamir Alshammari. Thamir is an advisor to the president of the Saudi Food and Drug Authority. He is a pharmacoepidemiology and pharmacovigilance consultant. He is a distinguished expert for the Chinese National Drug Safety and Policy Center in Xi'an, China. And he holds a number of titles, including serving as the Dean of the College of Pharmacy at the University of Yale, as well as the director of the National Pharmacovigilance and Drug Safety Center for the Saudi FDA. And of course, it's worth saying Thamir has been on the journey with us for quite a bit of time, including being on the UAMIS task force, being part of Charybdis and a number of our ongoing studies. So we are just delighted to have his perspective here today. Welcome, Thamir. And rounding it out, we have Dr. Rohan Khera, who is an assistant professor in the section of cardiovascular medicine. He is a practicing general cardiologist at Yale New Haven Hospital, specializing in data science, health policy, and outcomes research at Yale School of Medicine, and an investigator at Yale Center for Outcomes Research and Evaluation. Dr. Khera's research focuses on evaluating the quality of care and patient outcomes across hospitals in the US and identifying targets for interventions aimed at improving the outcomes of patients. Now, what's really exciting is that Dr. Khera is also part of an ongoing OHDSI initiative. I believe you are a lead of the OHDSI Legend Type 2 Diabetes Initiative, and we're really excited to have your expertise. So welcome. I'm delighted that we have new friends and old, and I really want to kick this off with, since we have a lot of family on the panel, I want to start with Dr. Wang. I think we are just delighted to know that you're here today. And I want to start with a question around, given your experience, you're a big proponent of establishing transparent and reproducible evidence. What are your initial reactions to this finding? You're a co-author, I should say that. Spoiler, Patrick is so excited. One other voice exists in the world who writes these kinds of papers and asks these kinds of things. So I want to kick it off with your reaction, and then I'll turn it to the other panelists.
Sure. So I guess my first reaction is that reproducibility and validity are different, although they're related concepts. And if you can't reproduce, then obviously you have a transparency problem that needs to be resolved before you move on to replication and robustness analyses. And on the other hand, the ability to reproduce results with the same data and the same analysis is not confirmatory. It means that the methods are clear and reproducible. So this means it's easier to do a thorough validity assessment, and confirmation requires different data, robustness requires different methods and or data. Also, the thing that Anna mentioned about sharing code is great. And one thing, especially with respect to sharing code to generate cohorts, that's very important would be the automated preparation of very detailed information on those scientific decisions. Because if you're going to be passing code packages around before you press go, you need to be able to understand what's being done to generate the cohort. Like, you're not going to necessarily read through the whole package. You need to understand what's happening. Are the choices reasonable? Are they the best choices? And the 6 teams showed that we need to be very clear and very specific in our communication of those decisions to allow that assessment of validity and then further interpretation. So I think the process, this was like beautiful, like so beautiful, all going through it. The first step, how clear are you about the science and implementation? Is it computationally reproducible? Yes, Mitch and Co demonstrated that. Is it independently reproducible using the same methods and the same data? Possibly. The 6 teams attempted it based on the published methods. We didn't see the results of that except for the cohort sizes, but it'd be great to see more details on that as well. But once you've established that, then you fully understand what was done to generate the results. Next is the very thorough validity assessment, trying to understand each decision. And Yasser did a lot of sensitivity analyses and nicely outlined the justification and learnings from each. But one external analysis that could be done is to evaluate how strong would a confounder have to be to generate these results. And I'm not a clinician, but I was very curious to understand the population better, because in the initial paper, it looked like the patients weren't very sick in terms of lung disease. Like, there was very low baseline exacerbation rate coupled with very low use of controller medication at baseline. And there are steps therapy guidelines for COPD and asthma, but the way that the covariates were parameterized, all of those were lumped together and mixed with adherence. So it was really hard to tell how severe lung disease was in this population. And you'd be curious to see what the table 1 looks like for the studies done in other databases. And also, I note that the number needed to treat from the original study was about 100. I'm not sure how, what that means in terms of clinical impact and all of that. But all of that was a digression. So the next logical step, as shown through this fantastic sequence of projects, is that after confirming reproducibility and understanding of the scientific choices, is assessing whether it's replicable in different data with the same or different choices. And each of these increases confidence in understanding of the finding: transparency, computational and independent reproducibility, replicability in different data, and robustness checks to evaluate consistency. But underpinning all of it has to be that thorough assessment of the validity and the relevance of the choices for the question being asked. Could there be better choices or reasonable alternative choices that could affect results? And I guess that's my 2 minutes reaction.
It's fantastic. And I think it's like a softball over to Rohan as the clinician on the panel, and we gave you some prep to ask you around sort of the class and ingredient effects. I'd be curious to know your reaction hearing Shirley's questions just about, context in the clinical setting. What were your thoughts on this particular exercise?
I think the scientific merit of the exercise is obviously, very well stated. Just the idea that you could replicate a finding that, has, modest biological plausibility, but replication across trials, again, across different population groups with different baseline risk of having asthma exacerbations or having chronic lung disease exacerbations. It was a key aspect for me. I did review after the study came out and in advance of this call, what are the biological mechanisms that may be at play? And there are changes in the surfactant or the inflammatory milieu. But the bigger problem is that, we can't sort of biological plausibility is probably the worst causal sort of pathway to go after. And the idea that being able to replicate in clinical populations where there is low risk of confounding is the key aspect here. And I want the numbers that you see here, there are only modest number of events that happen. And I think that actually reflects the, if you actually check the outcome tables for the main study, there are very few events that are actually happening in the people that were selected into these groups, which actually does highlight that they at baseline, even the DPP4 arm, you didn't have a lot of hospitalization events, which probably would be, suggestive that the study was handicapped in a way to get from the get-go in detecting a large enough effect. But the fact that it did detect an effect is somewhat reassuring, and that effect replicated across different populations is also reassuring. The aspect that I don't have maybe as much insight on is what would be considered So the other aspect is that these drugs have become very key in patients who have cardiovascular disease and diabetes. So what proportion of the population would not have cardiovascular disease, would have diabetes and would have a reason to use these drugs for additional indication of lung disease. That's a population that we cannot know. The Venn diagram of patients who have diabetes without ASCVD but have lung disease. That's the group that this actual study would most beneficially target.
It's extremely helpful context. As a non-clinician, I'm constantly trying to understand how to sift through those Venn diagrams, so that's really important. And I want to turn it over to Thamir, and you have a tough job. You are constantly advising regulators on how to just distill this information and process these types of, frameworks. And I'd be curious to know just, how does this change your thinking, or is it sort of building on your own sort of work? What are your reactions?
So yeah, this is really, as you know, it's really debatable topics. Everywhere you go, you'll see people talk about like using of real-world data and evidence for regulatory action and approval and all these things. So based on these data, and especially with the growing of real-world data and evidence, talk about this part of the world or even by the, for example, well-known by the US FDA or even EMA. What we saw yesterday and today, and especially today by Yasser, Anna, Mitch, and later by Christian, it's really a good work that's data being resolvable and also replicable. And we see a matter of these results. This really give you an report that the real world really can be helpful in the area as a regulatory action or recommendation. However, when you look in deep, there's some things that you really want to tackle. I will just quote Yasser when he said in his presentation that to use a clinical trials to confirm the result. I know Patrick a little bit considered this as not really an option, or not an option, as like to support. I believe going to RCTs all the time is not really an option for different regulatory authorities. So, and even considering the cost, and even considering the results that, for example, in OHDSI have a series of databases, transparent methodology with good quality, starting by Yasser paper and then what Mitch and also Christian did. So it's really give you a big confident to advise to consider this for a regulatory body. However, we need to think of some points like having most of these are in the States. So I'll be more comfortable to have more like another study, observe like real world data study from like Europe or even from my area in the Middle East to confirm that. And the other point is the safety aspect of these medication in this population. We have some information, but also we need to safety as well as a regard. Thanks.
So I think I'm hearing more work is needed. Shoot, we thought we were off the hook. We did such a great job. We were done today, right? I'm going to come back to a point you made in just a second, but I want to give Yasser an opportunity just to react to. So as the first author who was subjected to this process, and now you've heard some different perspectives, just what are your immediate reactions? And kind of, I know you've been such a good sport, and we're really grateful to have your collaboration, because I think that's part of how we really pressure test this process.
Thank you, Kristen, and thank you for the panelists for the discussion. I would not like to talk about the clinical implications of this exercise, but how this impacts on us on dealing with the real world data, real world evidence. And I just want to share that I learned a lot through this collaboration in terms of transparency and assumptions. Patrick and Mitch had several assumptions about what I exactly did from just reading the article. And when they reached out, these assumptions were cleared out after meeting and talking through what I did exactly. And that helped a lot. And this taught me that transparency is critical. and it's not something that we do not need often. I think we need it for every paper that was based on real-world data. And that should receive more coverage and discussion, especially nowadays, where everyone pushing for using real-world evidence in the decision-making. And I believe that OHDSI approach to real-world evidence and real-world data analysis and science in general should be the way to go, because transparency and collaboration will always be the key to science implementation and rapidly informed decision-making. And in terms of the clinical implications of what we saw today, I still that because it's specific population and the second-line therapy in patients with type 2 diabetes, often the prescribers are agnostic when it comes to which one to prescribe for the second-line therapy. Are we going to prescribe the SGLT2 or we're going to prescribe the DB4? And the analysis from today's exercise will give them some justification to give the patient with chronic lower disease the GLP-1 receptor agonist. But does that mean that there is a causal effect? I think that needs more analysis and more, especially for some measurements that we lacked from the data we used from the original database, such as the lung functions, which I believe is much more important than just using proxy measurement, which is the hospitalization admission.
Sure, blame the data. It's always the data's fault. I'm just kidding. I empathize heavily with wanting things in real world data that don't always exist in the format, or they're not one-to-one. So I want to double down on a point that you made, Thamir, because it's Patrick's favorite thing to ask, and it was in one of the poll questions. So this statement around randomized clinical trials are warranted to confirm our findings. I'd like to just revisit that for the group, not to pick on you, Yasser. Actually, I think there are probably clinical endpoints that may or may not have been, accessible in the information. So just kind of hearing that statement, now that you've seen this whole process, I guess what input do you all have around sort of, is that really the line we should use? Should we say things such as what you said, Yasser, which is, optimal information around lung function, not captured in a claims database, but would have been, really a good the good measure. I'd just be curious to know. I know you all have different levels of familiarity with how much information is or isn't in these databases, but it feels like that statement gets used a lot. And I'd just be curious if your thoughts had changed at all in this, or if you have any, in more specific language, since we want to be really actionable, right? And maybe I'll call on Shirley first, just because she's up in the corner and it's been a bit since we've heard from her.
I'm sorry, I'm not entirely sure what the question is. Could you repeat? Sorry, could you clarify what the question was?
So the statement, randomized clinical trials are warranted to confirm our findings, it's a great statement, but we have, seen there's a lot of information we can do outside of that setting. So I'd just be curious to know if that statement holds true for you, if you think there are maybe other, there's another statement we could make that, is more actionable that we could take as a community, since we can't conduct clinical trials, but we can certainly improve our analysis processes and think critically.
I don't know if I have a pithy statement, except for digging deeper into understanding what the differences were, like with age and or time and or that sort of thing, might be helpful. And then also thinking more specifically about, if you were to do a target trial, what is the target population? Is it going to be necessarily everyone with a diagnosis of COPD, or are you going to be looking for exacerbators, or being a little bit more specific about who you might seek a secondary indication for, and trying to target and just do a little more digging with real world data before even calling for a trial.
Do others have thoughts?
Can I?
Go for it.
So I think when you have a data evidence, it's already there, and I will start it there, and you confirm this evidence by they another from different database. I know it's from the same country, but it's different. It's different database manipulation. If you have enough money, if you have enough time, you can do randomized control trials, clinical trial. But again, so let's talk about all the regulatory, focusing on utilizing the real world data and evidence, and we can learn like the approval of medication by the ISPE. I think we have 1 or 2 medication already based on the real world data, and also we can learn from the pandemic itself. It's really, and I would just second what Yasser mentioned about the transparency by OHDSI, and the good example by OHDSI that's the transparency of the data. We answer many questions, or OHDSI answer many questions during the COVID-19 experience. Talk about the use of ACE inhibitor in the patient with COVID, use of hydroxychloroquine. Yesterday Albert described his study very effective, and before the clinical trial stopped, the medication really decreased in the utilization, and there is no need for characterization. Having a huge number of patients also help and have like evidence or confident to use that. So in this situation, having I just if you want to say that, I would love to see this, definitely not RCT, because I think we don't need to do an RCT. I would do like maybe different population, like since Danny is here, so like use CBRD or other data in Europe or in different parts of the world. So just if we see this patterns, I think I'll be comfortable to say yes, we need to use these data as real world evidence to have approval for this medication.
I mean, I can chime in a little bit here. I think the biggest barrier when, as a clinician, and or maybe even looking at, say, I'm making decisions that should our practice take on this drug among patients with diabetes and chronic lung disease. The biggest barrier right now is that we had these 700,000 patients who were screened for enrollment GLP-1. 23,000 of them had chronic lung disease and were receiving GLP-1s at this current time in the current analysis. That tells you that the current use pattern may not be reflective of the denominator population of patients with chronic lung disease. And we have to go, and the biggest unknown for me is what is the denominator population of diabetes and chronic lung disease that exists in the world? How is that substantively different from the patients who ended up being on GLP-1s in these data sets? And if that denominator population reflects the comorbidity distribution or the clinical description of patients who receive, or they're generalizable to that population, then we can go from describing this association to actually, prescribing based on that association. Because that's the biggest barrier for us, right? Going from this descriptive analysis to becoming prescriptive with this. And the challenges that emerge from that, not just having a product labeled indication, which is a regulatory bar, but a clinical bar is, do I trust this analysis enough to take that patient that I was not going to give GLP-1, who's currently not represented in the population, and give them a GLP-1 because of this analysis? And that's the biggest jump we have to make.
I would like to jump in, and yeah, maybe it's a question also to Rohan, since he's practicing. So the question now, what's the practice nowadays when the patient comes to the clinic and the patient, she has or he has a chronic respiratory disease, asthma or COPD, and also type 2 diabetes? What is the current practice? Do they prescribe them GLP-1? Do they prescribe what the guideline says about that, and how the analysis from what we've seen today can impact that?
That's a great question. I think the current practice for us is, if you look at the American Diabetes Association guidelines, the recommendation is currently SGLT2 inhibitors or GLP-1s are not considered first-line therapy. They are considered escalation. First-line therapy remains either metformin or, for us, even classes of sulfonylureas, which are not considered, which don't have any known cardioprotective effects. So, but the second layer of these drugs is patients with elevated cardiovascular risk or established cardiovascular disease. You are suggested to either begin SGLT2 inhibitors or GLP-1s or both. If the person has preponderance of heart failure risk, then you choose the SGLT2 inhibitor. That's actually not a codified recommendation, but one of the assessments from the trials that heart failure outcomes were most affected by SGLT2 inhibitors. But if you see ASCVD or atherosclerotic cardiovascular disease, then GLP-1s seem to have more effectiveness. There is actually no recommendation per se of other modifying features, because you started off from a diabetes population, you've come to this clinical CVD population, but you've left off the entire population that got metformin and sulfonylureas and doesn't have CVD. But if they have a risk enhancer in your particular analysis, a chronic respiratory lower lung disease, would that guide us to choose these drugs in a particular that population or not? That's not a recommendation.
That's extremely helpful context. I think this was actually something we struggled in the reproducibility workshop. We asked a lot of questions about what about this or what about that. So I think that while some of you weren't in that exercise, I think there were probably some of you in the chat who wish they knew that while they were doing the definitions. And I guess I want to take a step back. So clinically, we have a lot of questions, it sounds like, around just the utility, and this is really helpful. But I'm just curious, methodologically, you guys all have different experience from different studies. Just was there anything that surprised you about what you expected? We know heterogeneity in the methods is very common in a lot of the work we've seen. Some of the early OMOP experiments were, which method will reign supreme? And as the OMOP Cup showed us, we are no closer to the answer what reigns supreme so much as what are the considerations in design. So I'd love to hear if this process gave you any more perspective about that, or if there's any surprises that came up in your own kind of distilling from your points of view. Shirley?
I think the process was very logical and made a lot of sense, and it was just great. The only thing that surprised me was how strong and consistent the effect is. It was really, really strong. We don't see effect sizes this strong very often, so that is surprising.
I think having a consistent effect estimate. Sorry, you don't want to interrupt.
Go ahead. No, go ahead.
I think having a defect estimate that was so close to each other. I mean, again, a 20% alternate reduction is huge, as Dr. Wang said. But I think the other associated point is that it's also fairly consistent, which I don't really understand per se. That there must be really no interaction with severity of disease at all for you to have such consistent effect across the board in different populations.
Yeah, so Yasser will invite me for a dinner because of the code thing it is really reproducible paper in this work. I agree with Shirley that the strong almost similar results that we get from both the Mitch work and also Christian work is really tell us that how transparent and good and strong the OHDSI work that they had done, and it's not surprising. It's more promising that most of the data that we have is really dependable, and we can use them in the either in the by pharma, by hospital, and also by this.
And I want to be receptive to the discussion that's going on in the chat. And there's actually some really good questions around design choices and observational design that, were there alternatives that may be helpful? And Mark asks, do you have some recommendations on other design choices that would be important in moving reliable evidence forward? It's directed at Shirley, but anyone's welcome to weigh in. I think it's a really interesting question.
I didn't have any specific thoughts on design. I mean, self-controlled may not work that well here, given the Kaplan-Meier plot. It showed that the effect didn't happen until 50 days in, and then it was sustained, so that isn't really suitable for self-controlled, but maybe more along inclusion-exclusion criteria, because that can change your population. And as Rohan mentioned, that the effect is so consistent when you've got young, poor population versus elderly, that there's no effect modification on the multiplicative scale. That's just something more to examine, not necessarily with design, but I think you can dig deeply in to better understand these results in different populations.
And one of the aspects from earlier this morning that I was You were very gracious in sharing the code that was around creating the cohort and the cohort definitions. But had the investigator replicating the study not had that access to the decisions that were made in defining a cohort that specific way, and just had a description of a population the way it is described in papers and is often the case, would we have reached a different conclusion? Was an outstanding question for me. Could I have just thought of a chronic lower respiratory disease population, patients who got GLP-1s but didn't have access to the cohort like we did, and then create a full cohort like this and come to the same conclusion?
Thamir, did you want to weigh in before I see another very compelling question I want to ask, but I want to give you a chance to respond.
I'm actually, again, the same thing that I talk about, which is I would love to see this, have it in different population, different like maybe age group, and even different like maybe comparator as well, SGLT2 maybe. So this is I would love to see it. So.
Well, Aza is joking. We have 9 different cohorts we can run the analysis on because we did have a multiplicity of interpretation. But there is one question for Mark that I think is a good one for you, Rohan, which is you mentioned utilization patterns, or there's some differences there, and it's important for clinical decision making to understand that. So what utilization reporting are we missing here? What should we maybe provide if we were to amend this, thinking about that going forward?
I think understanding the baseline population that should have received these drugs. Essentially, currently our cohort definitions begin at diabetes plus, diabetes, lung disease plus GLP-1s or DPP-4. What we miss is just take out that drug exposure for now and just examine people with. I know having a drug, an active competitor, is a key aspect of OHDSI in creating the comparative effectiveness populations. But the flip side to that is then we miss the denominator population where these estimates will be applied to, which are people who are currently maybe not receiving any agents whatsoever. So just knowing that population, the characterization of that population, even descriptively to a sense, are we systematically people in one group are different on a lung disease scale, maybe a consideration for taking the next step. I hope I answered the question that Mark posed.
I think so. He's a tough question asker, so he'll give you some snark later. I want to kind of like put a bow on this, and really because the journey is beginning, right? And there's so much more work that we need to do. So I'd like to spend a few moments as kind of we get towards the end of our time together. Just what suggestions do you have for the OHDSI community as we mature this reproducibility approach? What concerns should we keep in mind? And I'll go backwards this time. I'll start with Thamir, since you always get the last go of it, but we'll start with you.
I think what in this previous being done is really promising. I think that OHDSI should continue doing this, explore more databases. Definitely this working must be published, so other like all people know about this effort. Again, just doing this work like databases again outside the US, Asia, I think another part. So this is what I advised.
I'm going to tag on one follow-up since it's a good question. How strongly do national agencies weigh evidence from data sources from different nations? Since you've made this point a few times, I just want to kind of have some context. I think Mark asked it, it's a good thing to know in the context of your comments.
Yeah. So usually in this part of the world, they really know what's databases, or what like either the databases themselves, like HR claims data, or even from the country themselves, like US or European. So they have scale. So we know which one will be better. For example, US data and Europe is better. Also AHR data, since we don't have a lot of claim data. So will be like more than the other one.
That's helpful. So I'll keep going around the group. So on this journey, Rohan, what should we be thinking of going ahead? What's your advice for us as we mature this approach?
I think some of the things that have come up in this conversation before is, because OMAP is a PAN format CDM, it allows us to incorporate EHR into this entire mix. So being able to do more work that adds some mechanistic implications, especially on the severity of the disease scale, from the, having those measures. Again, it's not to discount the work that it's done in claims-based data set. It's just to augment and find some sort of reproducible signal in another data set of that sort, not to go to randomized clinical trials, but actually enhancing the evidence base within the observational cohort itself.
Makes sense. And Shirley, what do you think? You are, I would say, the world's expert in this space. And we haven't talked about repeat a lot, but I'd really love to know your advice as someone who has just been working on that reproduction replication space that is adjacent and in the middle of all of this, right?
I guess my 2 cents is where I started, where that to just keep in mind that reproducibility and validity are separate concepts that do go together, but just because you have one doesn't mean you have the other. And just because you can't reproduce something doesn't mean it's not valid. And I think the process, it's like the dream, right? Someone does a study and some sensitivity analyses, and then people go out there, they reproduce it. They do it, replicate it in different databases, and that's the way that science progresses and we learn. And if OHDSI can do this in a more structured or formal process with multiple international databases, that would be huge. Like for all of these really big, impactful decisions, if that could happen, especially at this speed, but with care, of course, and then dig deep into, because things are going to be wonky, there's going to be weird stuff going on. But to dig deep, once you have all of that, that would be just incredible.
No pressure for the team. Yesterday, Danny wrapped his session talking about Christmas lists or holiday wish lists of what we can deliver. And so, Yasser, you've been part of this, and I'm curious from your perspective. So you've been kind of living with us as we built the plane while flying it and figuring out all the nuance. And just what's your takeaway of advice for the community? And is this changing how you're doing research?
It's absolutely changed the way we think about research in general. As I said about transparency, when we do things, science is not about the question itself or the answer itself. It's about the way we answer the question. And if we are not transparent enough about how we got from question to answer, then reproducibility will not solve anything. Because if you don't have what the researcher did actually, you will not you are reproducing other things other than the actual research. And my suggestion to OHDSI leadership is that do not get enough of collaborators. Seek more and from everywhere. And that, I think, will be the future of real-world evidence.
Do I hear you volunteering a whole group of people on their behalf? Jokes aside, we would love to include your research committees. I know some of you are already in the heart of some of our ongoing research projects, but Yasser, Shirley, you're our neighbor, or for some of us, you're literally down the street. We'd love to get more connected to ongoing projects. We'd love to understand candidate studies that could go through this. It's not trivial how good Yasser's paper was that made this possible. So thank you, Yasser. And I think, we're getting close to the end of our time. So I'll give you guys like 90 seconds if there's any remaining things in your heart that you want to make sure you tell the community before we wrap this phenomenal discussion. I'll leave it just for a moment. And any closing remarks?
Just what thank you, Kristen, and the OHDSI for having very, very important topic to talk about and having such expert. Just to continue what I said, we need to continue doing it work to help our patients, to help also the regulatory and pharma people in area of real world evidence.
Go after Dr. Wang.
I don't have any other final comments.
No, I would just sorry, if you want to say yes, sir. I was going to say. I was going to congratulate Patrick because, I'll be honest, I was a naysayer when he brought this up on one of our legend calls before. I kind of said this is not going to pan out. I kid you not. But I think the lesson I learned is that if there's biological plausibility and the effects are going to be too small for clinical trials, has to be a mechanism to provide the care that our patients need somehow. and actually refine the care, make the care more precise to our patients. And this is the mechanism to go after that. And I'm glad, I'm just so thankful to the community to actually put in the effort to do this and demonstrate this. And I hope we can like put it out there, as some sort of like document that demonstrates that this was done at this scale.
Yes, and I just want to shout out to Patrick and Mitch, because these two guys made this possible, and they were very, let's say, friendly to replicate and reproduce my work, and I enjoyed working with them every day when they were trying to reproduce my work. Thank you.
Well, thank you all. I think it's worth saying that, Mitch joked, how scary must it be to have Patrick call you up and, hey, I read your paper and I want to recreate it and I want to read your code. I would be terrified. And I love Patrick in our community. So
I didn't know him, and that's why I agreed to work with him.
You're a good sport. Thank you to our panelists for taking the time out. It's really critical to have your input as we go through this. I think Patrick and I can tell you we had a lot of fun hoping and praying that you'd join us and see this kind of culmination of this story. We had some doubts along the way, but I'm really excited to just be part of this journey with you. And I really look forward to finding ways to collaborate with each of you.
Thank you. Thank you.
Echo my thank you to the entire panel. It was a great conversation. I think it gave us a lot of food for thought for figuring out the next steps. So thank you very much.